Dave James. I'm the Head of Adult Social Care Policy here at CQC, and I'll be taking us through today's session. So, am I driving these slides? I'm happy to.
Sam is.
Okay. So, if we just move. Apologies. So yeah, just it's a bit of housekeeping before we start. So if you do want to ask a question at any point, or make you can use the chat box for any comments, or please do feel free to raise your hands. If we can all make sure we're on mute, that would be fantastic. When we go into our breakout rooms, if something comes to mind which is perhaps slightly outside of where we're focusing, then do feel free to log that in the chat function. Or you're going to use that as a parking area, and we can come back to that as we write up our notes and make sure we don't miss anything. We're going to do our best to stick to time today. And just to say that our session in the main room will be recorded. We're not recording our breakout rooms, but our main room session will be recorded. And today's all about working together. So that's, if we can all be non-judgmental and respectful in how we work and supportive, it's really important that everybody gets a chance to speak, and that everyone has a voice, and that we listen to what others are saying. So we can go on to the next slide, which I think is the sorry, I'm not synced here to the agenda. So welcome and introductions, and then I'm going to talk for around about 20 to 30 minutes. It may well not take that long, just to kind of bring you up to date. Some of that will be a recap on the developing approach that we've been working on. Some of it will be newer, and that will set us up for our sessions in the breakout rooms. There'll be a chance after I've gone through that presentation just to kind of clear up any questions that are arisen. And then we'll have about 25 minutes in our separate rooms to have that more focused discussion. Coming back at 11:15 to hear some of the key points that people have raised and some of the things that have come out of those conversations. Wrapping up by 11:30. So essentially today is about, as I say, an overview of where we've got to on developing our new model, and updating you on what we've done since we last spoke to you, and looking forward to what's happening next and how you can stay involved as we continue to develop this work. Okay, so I'm going to talk you through, as I say, a little bit of a recap, I think, unless this is your first time at one of these sessions, and then setting us up for our conversations in our breakout rooms. So on this first slide, we're just setting out here how our proposed future approach differs from what we do now. So at the moment, we have 4 assessment frameworks. I'm in that top left-hand square there. We have one for health, one for social care in terms of inspection, and then the same again on our registration side. There is quite a lot of duplication in that. You might have spotted it yourselves. Some topics are spread out across different key questions, and they are quite long as well. And so if you could just stay on mute, that'd be fantastic. Thank you. I think the other thing to say about the assessment frameworks, as well as the kind of the complexity, the length, and some of the duplication that sits within them, is it's been some time since we've updated them, and health and social care have moved on. So we really need to make sure that our frameworks are keeping pace with how health and care are delivered currently, and set us up for the future. The other key thing to draw out from this, I think, is at the moment our approach is very much about set piece inspections. So inspections being the way in which we gather evidence to support judgments. and we split up what we call our monitoring activity with our inspection. So we may well gather evidence as part of monitoring, but we don't go on to use that to form any judgments or assessments until we kind of step into that formal inspection. And it's very much a single point in time activity, even though we do have more focused approaches to inspections across the sectors. It's still very much going and looking at a range of material and then stepping out and considering what that means and making judgments. We use our key lines of inquiry and then take away what we've seen and found and line that up against our ratings characteristics, of which there are 70 pages. So again, just to underline that complexity and the density of our current approach, we don't feel, and we've certainly heard this back from our stakeholders when we've tested this, we don't feel that's as clear and as accessible as it should be. For providers and for people that are working in health and social care to understand what good looks like. And that whole process is very much, it kind of takes place in a sort of offline space. So it's very, there's not a lot of structure to that, I suppose. We think that we can tighten that structure up and there's opportunities there to be more consistent in how we apply our judgments against the framework. And what is produced at the end of our current approach is a heavily narrative-based inspection report with some high-level ratings at key question and service level, but really a lot of narrative, which we've heard is not necessarily serving all the needs of all the different audiences, and certainly doesn't support our ambition to be smarter in how we generate insight from our assessments and how we use that to drive other activity and to play our findings back to providers and to the public and to other partners and stakeholders. So what we're stepping into then is a single assessment framework, and I'm just going to break that down in a moment. Which will apply equally across all of health and social care, and not just to providers, but to our new duties in relation to local authorities and integrated care system assessment as well. And the process will be much more of an ongoing assessment of quality and risk. So really stepping away from that distinction between monitoring and inspection, it's much more about an ongoing program of evidence gathering and considering how that evidence lines up against our framework and updating our findings. And I think the other key point then to make is that this is much more about multiple points in time. We want to develop an approach that allows us to combine older evidence with newer, but within defined parameters. We need to be really clear, and that's partly what today is about. Starting to explore this. How old can evidence get? And we think that will vary depending on the service model, on the circumstances, and on the particular evidence itself. So a strategy doesn't need to be looked at every 6 months, but people's care plans and care records would be looked at more frequently. So it's trying to break this down into more sensible and manageable chunks to allow us to iterate our judgments in a much more agile way than we currently can. The other change you'll have heard us talk about then is using a scoring system. So instead of lining up against the very narrative ratings characteristics, we actually want to take the principles that those characteristics are trying to describe and put those onto a 4-point ratings scale, which then aggregates up to give ratings. And we want to do a lot more work to improve how long it takes us to write up those reports and the clarity of those. So we want to work out and understand what is it that different audiences need and how can we make our reports more accessible and to support providers and others to really understand strengths and weaknesses in provision. So that's now in the future in a nutshell. If we can move on to the next slide, please. So I mentioned the assessment framework, the single assessment framework that we are going to be applying to essentially everything that we do. So that's providers, local authorities and integrated care systems. We'll still be working to the 5 key questions of safe, effective, caring, responsive and well-led. But what we're doing, and really this is the starting point of our future framework really and approaches, we're bringing those 5 key questions to life using what people have already said in terms of what high quality and person-centered care means to them. And we're doing that by essentially borrowing from using the Think Local Act Personal Making It Real framework, which is a co-produced set of I statements which people who use health and care and other partners have essentially said that's what good looks like to me, that's what I expect, and that's what being treated as a human being and as a person really means in plain English. And we think that's really powerful, and people have supported this approach. It's a really powerful way of just kind of cutting through what can easily turn into lots of regulatory noise and narrative, and actually just starting from that simple place and having that as our North Star really is what's guided everything, and that's what we want to be focused on as we step into our future model. Stepping down into the next layer then, the quality statements, we've borrowed from the style of Making It Real, the Think Local Act Personal framework, because if you're familiar with that, you'll know they also use we statements. And they are essentially commitments that providers and commissioners and system leaders would make in order to deliver on that level of person-centered care that people have described in the I statements. We have largely not used the Think Local Act Personal statements there. What we came out publicly with and wanted feedback on was some of them were from Making It Real, but actually most of the we statements we have formulated. We've had to change those essentially because they didn't all work for all the different sectors that they need to. They didn't work for local authorities and integrated care systems, which a subset of those statements would need to. So we've borrowed from the really clear and actionable kind of language of the we statement, yeah, we've not actually used the ones from the Making It Real framework. Stepping down into the evidence, this is essentially what the key lines of inquiry have become. So what we found in looking at those 4 assessment frameworks that I mentioned, in particular the inspection ones for our main focus here, was that, well, firstly, we asked 335 questions, whether they were key lines of inquiry or prompts. In our documented methodology, there were 335 separate questions, which is quite staggering, I think, and quite a sobering number to be aware of. What we found is actually we are essentially asking 6 questions over and over again. But the reason that balloons so much is because the starting point in our current framework are those key lines of inquiry. So we roll in the topic and the source of evidence into each of those questions, and very quickly that's how you kind of snowball into that huge amount of questions. If you flip that around, and if you start with the expectation of quality, so the we statement pitched at good, it describes good, then you can ask much more simple questions. You can say, okay, so in relation to that, what have we heard from people? What's their experience? What do we hear from staff and leaders? What are we hearing from our partners? What have we observed in terms of observing care delivery or the care environment? What can we learn from policies, processes and procedures? And what does the data around outcomes and performance tell us? And really that does sum up all of those 335 questions. So they are part of the engine room of what we're looking to deliver here, and that might make more sense as we go through the subsequent slides. Really, those categories are what will drive our activity, and we need to develop rules to understand how frequently, in relation to different service models and contexts, do those 6 evidence categories need to be updated. So all of those 3 levels will be the same for everything across all sectors and across ICSs and local authorities. Of course, at the detailed level, the actual evidence we need to look at would be very different, and the actual best practice and standards and guidance would be very different across the different models of delivery. So that bottom tier is where we need to be more specific and tailor the evidence requirements to the model of delivery or to whether it's provider, integrated care system, or local authority. And that's the detailed work that we're coming to now. And as I say, underpinning all of this and keeping this up to date with where best practice is currently at, and clearly mapping that in our approach. If we can move on to the next slide, please. So there's just an example here of one of those I statements. So as I say, these aren't CQC constructs. This is what people have said, and as an example of one here. So when I move between services, settings, or areas, there's a plan for what happens next, who will do what, and all the practical arrangements are in place. And that would translate to this commitment that providers, local authorities, and integrated care systems would essentially sign up to. So this is what good looks like. We work in partnership with others to establish and maintain safe systems of care in which people's safety is managed, monitored, and assured, especially when they move between different services. And I think that's a good example of something that does make sense for a provider. It makes sense for a provider that needs to link in with other providers as part of a local or regional network. But it also speaks to what a local authority needs to be doing, and indeed a wider system needs to be doing. If we can move on, thank you. So the next few slides then, and kind of building on what we've talked about here, are trying to get to how does this all add up to a more structured and consistent approach. And what will be essential here is developing those rules for the different evidence categories, and essentially the timetables for how frequently those evidence pots need to be filled up. Going back to my point earlier that we're stepping away from the big set piece inspections and actually being more flexible in how we gather evidence and tailoring our approach to the evidence. So clearly, if we need to observe care, we need to be in the setting, but we don't need to be in the setting to review documentation or to look at data. So it's really tailoring our approach and making sure we make the best use of time on site, and that will vary according to the service model, of course. So community-based social care, there's not going to be really any observation, but in residential settings, for instance, or where there's we might have concerns of a closed culture developing, then we'd certainly be in there much more frequently and understanding how people are cared for, what the culture is like, what the interactions are like in that setting. So it really will be varied, and the rules for that will align with the evidence that we need. And the aim here is to arrive at those more up-to-date assessments, and through developing rules and a timetable for how frequently we need to look at things based on the context of the provider, we can iterate our scores. Essentially, I've talked about the scoring, and that we will be looking to score those quality statements, those WE statements. That would be driven by scoring the categories of evidence. So people's experience, we would maintain a score on a 4-point scale of what we're hearing from people, a score for the policies, procedures, what we're hearing from partners, and that kind of flows up to give us a score for the quality statement, ultimately updating ratings. So this is illustrative. I'm at great pains to say that. Please don't take a screenshot of this and think this is how it works, but this is just trying to bring it to life at a fairly high level in terms of the categories of service model. So we've got residential, inpatient, community and digital there, and then the 6 evidence categories along the top. So just in case, because some of this is, I think, is quite difficult to visualize. So this is just one way of bringing it to life. And this would, as I'll go on to explain in a moment, this would vary, but broadly, this is essentially what a national profile might look like for each of these service models. So with observation perhaps happening once a year in residential, similarly, us actively gathering people's experience once a year, potentially every 2 years, speaking to staff and leaders. But please don't take this as in any way carved in stone. It really isn't. It's just to bring this to life and give us some different numbers. So those first 3 columns are very much about what is it CQC initiates? What do we actively go out and gather? And I think these last 3 are a little bit more about what do we need to make sure that we're receiving in terms of what do we hear from our partners, and that might be an annual schedule across that top row. There would be different schedules for different standard data sets, which we would fit in with, and again, we're looking at developing a much more streamlined and friendly approach to how we request information from providers and also from local authorities and ICSs, and developing a digital platform to make it much easier to do business with us, essentially. So that kind of material that you just need to keep us up to date on. In this example here on the residential row, that would be like an annual update, but actually there'd be no reason why you couldn't keep that up to date more frequently. Okay, I'm going to move us on. So really what sits behind this, what kind of gets us to that table we've just been looking at, is a series of steps. And this slide is just trying to describe how we overlay different layers of activity to get us to that right-hand side of the page, which is where we are going on to make an assessment and updating our scores for the different evidence categories. So starting over on the left, we will develop essentially a kind of a starting position, I suppose, and national profiles based on service delivery model, based on what we know about risks in that subsector, or perhaps also based on national priorities. But that kind of gives us kind of a version 1 of what a timetable for evidence collection looks like. And then that starts to be modified based on the particular circumstances of that service, of that provider, taking into consideration any previous regulatory history or any other information that we're aware of. And also moving over into that third column of what is it we know more broadly geographically, and what are the patterns and trends we're seeing, and are there any particular areas that we need to be focusing on? And all of this modifies that timetable, which would be clearly communicated to the providers, and as I say, all of this applies to local authorities and integrated care systems as well. So it'll be completely transparent in how frequently we think we need to be updating our evidence categories. And then we're into that rolling cycle then, essentially, of maintaining scores of that evidence, which flows up to the ratings. And I think when we get into our breakout rooms, it'd be really good to be thinking about one of the central challenges here is, as we're describing what you could think of as kind of an always-on model, constantly building and iterating our judgments, there's a real risk that becomes just very difficult to follow and for providers, but also for the public. So we wouldn't want to be in a position where we're essentially changing published information and published assessments as frequently as evidence changes, because that could be daily, as I'm sure we all know. We don't want to be getting stepping into the shoes of providers and actually doing their work for them. There needs to be an appropriate balance, and we've certainly heard that before when we've talked about this idea. So what we're really keen to hear about is how would we deal with that, and what might be the kinds of timetables you would expect us to see in terms of updating evidence. And one way we've started to think about this is we can allow evidence to build up and flow into us, but for instance, we might consider that we wouldn't make any assessment of that any more frequently than monthly. So the kind of evidence builds up, and provided there's nothing in there which is flagging urgent risk, which of course we would always respond to immediately, we can allow that evidence to build up and then step into that assessment mode and look at, okay, what does this tell us about people's experience? Are we seeing a change here? Do we need to update our score of that evidence category? What are we hearing about the other evidence, the other evidence sources? And we can maintain those scores then. And another idea that we're really keen to test out with you all today is the benefits of exposing those live scores against those 6 evidence categories to providers on an always on basis. So you can always see those monthly updates, if indeed it is monthly, and it might differ for different service models. But perhaps we would have a slower update in terms of what gets published. So we would maintain an always on view for providers of their evidence category scores. What's published are the quality statement scores, those WE statements that I talked about, and of course the ratings. And what we're keen to understand is, can we set some rules so we don't update those published judgments unless there's a change, essentially, or unless the time period that we've set, and we need to agree these, and this is again what today's about, the time period for those being updated has been reached. So we would always confirm that a judgment is up to date against those quality statements on our website. So it's breaking it down into different components and different layers of detail, and what's useful for you to see and to maintain an ongoing view of, so you can see your direction of travel as providers, and how our assessments are squaring up against that, and versus what needs to be in the public domain. How do we make sure that's always up to date, but not too much, because it could just get very confusing. The other benefit that we think we would get from exposing those scores on a live and ongoing basis to providers is it might just reduce the need for the levels of challenge that we see in terms of factual accuracy and ratings reviews. If you can see on a much more up-to-date basis how we are considering the evidence that we've gathered or has been sent to us, you can offer other evidence. You can offer some other material that would balance that picture out, essentially. So we're trying to get into a much more mature relationship in terms of how we work with providers. And just to repeat myself, that would be the same for local authorities and integrated care systems as well. Quite a lot on that slide. But the next slide just brings to life a little bit how this might look for a GP example. Although actually that's all in the notes. So I'll kind of talk to this. So there's national profiles that I talked about. For GPs, the kind of vanilla version of that, the kind of starting point of that would be an annual update of people's experience. We wouldn't be setting a minimum for observation. We may well not be doing observation. Not all of the evidence categories need to be applied for every type of service. Sorry, my notes aren't making sense here. So essentially, yeah, a timetable for evidence collection as set out in that example table. And then how that would play out is an annual GP patient experience survey. We get those results annually. We receive annual vaccination rates, and we receive annual cancer detection rates. So that starts to to build up those pots of evidence. We would be seeing on a quarterly basis prescribing indicators such as antibiotics, hypnotics, controlled drugs, and so on. Quarterly updates on cervical cancer screening. Monthly updates on analysis of feedback from people using services, such as through our own Give Feedback on Care service or through the NHS Choices. And weighing that up against what we know about quality in that area or in that service. So in this example, the service is good. There is no flagging risk in terms of this service. There are some concerns in this geographical patch around access to services. So what that would do is that might just nudge the timetable and kind of ramp up how frequently we would be looking to gather evidence that lines up against that quality statement. And in line with that timetable, we're updating our evidence category scores. That hits a few of the quality statements. So the evidence will relate to different quality statements. And in this example, for instance, 6 quality statements are updated. Some scores have improved, some scores have declined, but none of that has been sufficiently significant to change the overarching rating, which is good. So just to bring it to life a little bit in terms of the different levels of interaction with evidence and how that plays through. So we're kind of at the start of the next phase of activity here. So lots more engagement to come in terms of getting into the detail of this process. From kind of late spring into the summer, where we're increasingly testing this out with small numbers of providers and continuing to develop our processes and our digital platform. And there'll be lots more opportunities to get involved and help us shape this work. I think we're on to Q&A. Yes, I did see a few flash up, but I wasn't able to respond. Does anyone want to raise their hand first of all and ask anything? I'm aware there's quite a lot of information in that set of slides. Ratimi, yes, please, thank you.
Yeah, good morning. Thank you for the presentation. My question is about the ICSs. There's talk that they wouldn't report directly to CQC because that would be creating another layer of reporting. Is that correct?
My colleague who's leading that work isn't with us today, but I think what I would say is we need to make sure we don't create another layer of reporting unnecessarily. We need to make sure that we link in with how NHS England already fulfill their duties and how we complement that and add value. And it's a similar issue on the local authority side. There's already lots going on there around how improvement is supported and driven. And what we don't want to do is just kind of step in the way of all that. We need to work out where do we add value. But I would expect that some information would be needed to be sent to us if it doesn't already exist somewhere else. That's our watchword. Same for the provider approach. If it already exists somewhere, we don't need to come and ask providers for it. We can use what already exists.
Okay, thank you.
Hope that helps. Thank you.
Thank you.
Jang, yes, thank you.
Hello, hi, good morning to everyone. Just a quick question, actually. So, having like a chart or a portal for real-time feedback as well, would that include complaints as well?
We would have that on our Give Feedback on Care service. We already have that option. People can raise concerns. We wouldn't expect providers to give us a day-by-day up-to-date submission of what they're hearing in terms of complaints, but we would. There is a quality statement in there that's about how people are encouraged to share feedback and people that want to complain are supported. So in line with the timetable we develop, we would expect providers to kind of evidence that. Yeah.
Because I'm actually quite new to the NHS. My background is private sector, been here for 3 years. I'm still finding my way around various things. One's been a complaints procedure as well. So am I right in saying that CQC actually investigate complaints directly?
No, we don't do that. No, we don't have the resources for that, but we will consider what kind of the insight that we can draw from those complaints and whether they point to specific concerns, and we would look to follow that up. We do want to get better at kind of closing the feedback loop for people in terms of when they've shared information with us, and we've gone on to do whatever it might be. At the moment that would be an inspection, whatever it might be, but we kind of need to kind of thread the line where we're not necessarily setting ourselves up as a complaints resolution agency, because we don't have the capacity.
So I'm assuming, so if somebody comes with a complaint to a GP practice, let's say they notify the local CQC area or department, whatever, they would signpost them to NHS England, for example.
Yes, that's not my sector, but that sounds right to me, and I'm sure anyone who does work in that sector would be able to clarify. But yeah, whatever. Yeah. Do
you think the other question I actually have as well? It's like, currently we're actually a bit in limbo because because of COVID, so on and so forth. So our actual assessment inspection was based on the previous process and framework. Now, what happens to people like us, like ourselves? Are we actually reassessed in the previous framework or in the new framework?
That's a great question, and I'm sure everybody on this call is in the same position. I think what that will probably look like is we need to transition. So we need to convert what your current findings are, what your current kind of ratings are, if you like, and the judgments were published, into the new framework. So kind of drop that into the categories that we have our clearer framework in the single assessment framework, and convert that into the scores, and that's kind of the baseline. So we're able to start from that. So that's our preferred approach, is to actually transition. We don't, in fact, I can rule it out. We don't need to go out and do a comprehensive program using the new approach. It's more about how does our current set of judgments line up with the future way that we want to structure our assessments and report on what we find. And so the baseline's already there.
Yeah. So, for example, in our case, we were our previous inspection, we required improvement on our long-term conditions. Okay. So what we've actually done, we've done a lot of work on long-term condition with the RCGP as well, and with the support of our CCG as well. And we're using Arden's long-term conditions template now going forward. And then we can see, compared to previous year's figures, great, there's a massive improvement, we're right trajectory, so on and so forth. We can quantify exactly our improvement. But now, correct me if I'm wrong, is that the CQC aren't looking at QOF figures.
Again, I'm not a sector expert on GPs. I'm not sure. I've got a colleague who is, but more broadly, your example, that is perfectly valid evidence for you to share with us. You don't need to wait for an inspection for us to be responded to that. We can corroborate that with other evidence. So for example,
we have 3 areas. Sorry to go on about this. So we've got 3 areas. I'll keep it quite brief. 3 areas. We need to show improvement on which we've done as well. So what you're saying, we can approach and go, by the way, here's the 3 areas, quantifiable, this is what we've done, these 3 areas, okay, and that would actually negate for us to actually have a full inspection again.
Yeah, that's up-to-date evidence that we can consider, and because we've got a more granular approach, we're able to kind of nudge the relevant scores up or down based on that. So,
right, thanks, Jan. Thank you.
Thank you. Lalani, please. Thank you.
Sorry, can I just say the name's Maronisa?
Oh, I'm sorry. I'm sorry.
You've got to learn to pronounce it.
I'm sorry. I'm so used to surnames being first.
That's fine. My name's Maronisa. So I suppose just to say thank you very much for this is the first time I've attended the session that you've kind of presented. I think my question is around the new ICSs, and I absolutely understand that there isn't another layer of regulation that you want to create. However, things are really going to be changing. So you've got, providers who are going to be working together. You probably are going to have providers in social care working together. And within that context, I really don't understand how this model is going to apply, because, in a sense, you've got what you have is a model which is about entity regulation, but not necessarily entities or the collaborative model regulation. And I wonder how that's going to sit in relation to kind of a regulatory model going forward.
That's a great question. So we are confident, and we've had a lot of feedback from people on the actual content of the framework itself, that the way that is worded, it does apply, but not all of it will. So we're not going to look at infection prevention control at a local authority level, for instance. That is very much about that as a setting specific standard. So it's going to be about what aspects of that framework make most sense to look at through the local authority lens, and what makes most sense to look at through the integrated care systems lens. So perhaps an example of that is there is a commitment in there, a we statement about ensuring there's enough suitably skilled staff and workforce. Clearly that's a provider issue that we need to stay on top of and make an assessment of. Potentially we could look at that at the local authority level, but actually what we're most interested in is what's the integrated workforce strategy at system level. So it's about pitching it at the right level, and sometimes we'll need to look at the same quality statements, but the evidence and the way that we gather that and the way and the kind of the lens that we apply to it would be very different.
Okay, that's really helpful. Just one final point then based on that. I think it would be really helpful for some clarity, particularly for patients and the public, in the way that model is going to work, because you'll see very soon that complaints are going to be more about, people are not going to know, who to complain about in terms of their provider context or that kind of integrated working system. And the CQC together with other regulators really need to look at this very clearly.
Yeah. That's a good point. Thank you. Wendy.
Hi, yeah, it's Wendy Winterbottom from Airedale. Just thinking about the data collection you're doing and becoming smarter with that, if you like, and collecting it more often. Will that feed through into the insight tool so that data that's within there is more up to date? We'll just start seeing that coming through in the insight tool.
Absolutely. Yes, it would. It would.
Good.
Yes. And I think that's it for the hands. Carol?
Yeah, thank you. Sorry, it's my first time on one of these as well, and I've been taking some notes. By the way, the GP example you gave, we couldn't see that. It was just a straight blank sheet, exactly the same as the care home one.
Yeah.
So we couldn't see that example. It would have been helpful. Sure. I'm really concerned that this is actually going to add work to GP practices rather than reduce it, which I thought was the intention, because GP practices are now individual businesses. They're part of the ICS. They're part of primary care networks. What I can see happen is everything you ask the ICS for, they will go out to the individual practices. They'll have to feed it back probably through the CCG and through the PCN, and it'll get fed up and it'll be more and more and more. And you have talked about site-specific information, and you've talked about policies and procedures. I'm sorry, it fills me with horror. It sounds to me like it's going to be a lot more work rather than any less or any more streamlined. Please give me some reassurance.
I mean, yeah, absolutely. So we are duty bound to ensure that we don't burden the system or providers. And I think a point that I should have made as I'm talking through is one of the benefits of breaking this down into its component parts is that we can be much clearer on what the required evidence is. So even though there are 6 evidence categories, it's not the case that we need to have evidence under all of those in order to make an assessment. At the moment, we are not consistent in terms of different inspectors. Some of them will go out and want to look at, spend the whole day in the office looking at policies and procedures. We want to be really clear when that is required and when it isn't, and design a system that actually essentially prevents us from doing that. There would be no benefit to an inspector to spend a day looking at policies and procedures when they ought to be speaking to staff, observing care. So a really big important part of this new model and the granularity that we're building is it allows us to set those rules. And I think your point about the kind of the blowback onto providers from our ICS assessments is a really valid one, and we need to make sure that that doesn't happen essentially. I suppose part of that answer will be, how do we use what we already know from provider regulation, play that into what we then take through to the ICS approach, and the evidence that we do gather and assess and our provider findings are a core part of how we go on to make an assessment, or how we will go on to make an assessment of an integrated care system. So that but we do need to be wary of ICS's pushing back, because that shouldn't be that's not what we're looking to design here. I think we have time for one more before we need to go into our rooms. Sue.
Yes, I just wanted to pick up on a question actually that my colleague asked in the chat, which was around how this model actually works with the relationship owner that we have as a trust from CQC. Like, will that continue? Will it be expanded? Because a lot of what you're talking about in terms of real-time assurance does come through that route. So I just kind of wanted to understand that a little bit more.
Yeah, and it'd be great to hear reflections as we go into the rooms on this. Our assumption is that would continue. It does work. We know it works. It can be variable, so there's something there about how do we make that a more consistent offer. But we're really keen to kind of extract as much as we can from that, I suppose. So relationship management at the moment would fit into the monitoring aspect. But as you rightly say, there's actually lots of valuable insight and information from that. And let's not feel we have to park that and then move it into an inspection process. It's actually, well, how do we play in what we're getting from relationship management and play that into our understanding of quality and risk? And actually, that's a valid source of evidence. It's feedback from staff and leaders that we've gathered through relationship management. We want to be able to use it rather than just consider it as a trigger for something else that we might do further down the line, such as an inspection.
I suppose what I'm trying to avoid is the duplication aspect. So if we're managing something through relationship management, and there's queries through that route, I wouldn't expect then to have to provide it in a different way.
Yes.
Because very often that does happen. So I think it's just making sure that we are tying those two things up. Absolutely.
And again, that will go back to us being really clear on what the required evidence is and building the rules around that, and essentially preventing that from happening by building walls around that evidence. But that's very much where we're at the moment, is how do we do this? How does it vary for different types of a provider, and what are the actual rules that we need to design?
Thank you.
Thanks very much. Okay. Carol, is that a legacy hand there? I think it is. Yeah, great. So I think, colleagues, we are going to go into our breakout rooms now for around 25 minutes. Is that right?
Yeah, that's correct.
And you're going to whiz us in there, Steph?
I will. I think the breakout room questions are just on the next slide. If everybody just wanted to have a quick peek before I release everyone into the rooms. Just a quick note to say that I'll be hanging back in the main room. So if there are any sort of like technical issues and such, and you kind of don't make it into your breakout room, I'll be kind of on hand to work all of that out. But I'll send everyone off now.
Thanks, Steph.
From room one, there was a couple of key points. So I think that concern about the duplication between provider level and ICS level was coming through quite strongly, and also maybe a slight worry about more overlap between our regulation and professional regulators as well. So I think there's just a bit of anxiety around that we might want to say a bit more about in the future. So kind of be a bit clearer about how we're not going to be duplicating and how we'll work together to avoid that. Some from room 2, we talked about the importance of corroboration around evidence. So I know there was some concerns around people's experiences of care, and you know, how would we check that those are actually valid concerns about a service? How would we put evidence alongside other evidence to make sure it told the same story, etc. And we talked about the importance of making sure the new model addresses consistency or current inconsistency to be more accurate. So that's both about consistency of assessments, but also the consistency when we report following an assessment as well. We talked about the importance of making sure data's up to date and understanding and probably wanted to explore in a bit more detail what's the lifespan of specific data sets to make sure that the collection frequency is right. So that's going to be quite important. And also talked about something we haven't talked about that much today, but actually quite important to people, is that we're able to share all the information and data we hold for providers in a way they can use to benchmark themselves against others. And then there was some feedback from room 3 as well, that it's a big positive of the proposed new model is that ratings could be updated more quickly and frequently, which would be welcomed. But also concerns that they see the potential for an increase in burden in the new model if we're talking about kind of ongoing collection and assessment, etc. I think there was definitely a call for us to share more information about how we do things like identify risk and re-rate without an inspection in the future. What might that actually look like in practice? And again, on the duplication question. And I think there was something about looking at the outcomes evidence category and really thinking about what's realistic to expect from specific provider types in terms of outcomes that could be measured there. So I guess kind of, you know, taking that realistic view of what's possible there. Then for room 4, definitely a big positive about it being, you know, more timely, up-to-date ratings, etc. Definitely a big improvement in some of the long frequencies between inspection and rating that we had in the past. So that's definitely a big positive. And we also had some feedback from room 5 around again, the kind of duplication between system level and provider level assessments and making sure we avoid that. Definitely an appetite to get into more detail on our scoring approach. So running through what that might look like. There was a specific question about how this might be applied to the dental sector, where we've obviously got quite a different model at the moment, and a bit of interest in how what that's going to look like going forward, how that model will change, etc. And I think I've run through most of the main points there, but others from the rooms might want to jump in with comments.
Thanks very much, Sam. I mean, certainly one of my reflections is just how kind of helpful it will be when we can share more detail. And the phrase that was in our room that was used just at the end was that the devil's in the detail, and it really is. And it's some of this is quite hard to visualize until you kind of get to that next level of detail. So I think that'd be really good to get into over the coming weeks and months as we develop this and seek your input on that. Anybody else want to come in with any reflections, though, just to complement what Sam was running
I think
through?
Dave from room 3 that it was very much, it raised more questions and, you know, requests for more clarity.
Yeah.
Yeah.
Oops, I just pressed the wrong button. Turon, oh, sorry, had a hand up then. Yeah, do you want to come in there? Turon Karim. You might be having the same trouble as me with the mute button. Oh, and the microphone. Oh, it's just not. Well, we can come to Jane first and then perhaps come back if it starts working again. Jane Earl. And your microphone's not working either, I don't think. Oh gosh, we are beset. No, we're not hearing you, Jane. Really sorry, really sorry. Has anybody got a comment and a microphone that's working? It's clearly Monday morning in computer world as well as in our world, isn't it?
My mic works fine.
There we go. So someone coming in then?
It should be very interesting. Quick question for you. So what time frame do you have for this?
So I think there's we're continuing to develop this. It's very much developing the approach through these engagement sessions. Towards the end of the sort of middle to the end of the summer, we'll be starting to test this out with small groups of providers, just to really start to put some flesh on the bones, and it's gradually building up from there through to kind of spring of next year, where we'll be starting to really start to implement more. So there's plenty of time. I would definitely want to stress that to understand what this means for your circumstances and to input so that we can develop it together.
Oh, yeah. So have you already selected, for example, GP practices that you're going to be working with to sort of iron out the creases regarding this new approach?
I don't think we've got there yet. I'd need to check that, but I don't think we've got there.
Is that something that you'll be considering?
Yes, certainly. Yeah, we will be. I can check that up with colleagues that are working on the testing and implementation for sure.
And would you be able to throw your hat in that ring as well?
Sure. Yeah, we can. Yeah, we can pick that up. Okay.
All right, good.
Thanks, Jan. Thanks, everybody. I think we've got one or two more slides. So thanks just again for participating today. I do appreciate. I think a lot of the comments have been about how difficult this is to engage with when there is so much detail, and that's something that we can certainly share as we go on. So please do stay alongside this. There's different ways you can do that, of course, as well as these sessions. There's our digital platform, signing up to our bulletin and blogs via Twitter, and linking into our CQC Connect, where we are putting podcasts out there as well. But so that's all to supplement these more targeted engagement sessions. Carol, did you want to come in there?
Sorry, yeah, it was just a quick one on that last comment about, you know, the GP practice wants to throw its hat into the ring. Frankly, if you're going to do this in the way that you're talking about, you can't just have individual practices throwing the hat into the ring. Yeah, sure. You need to talk to the PCNs and the ICSs to make sure that somebody is prepared to test across the whole range of providers, not just individuals. Just a comment.
Yeah, no, thanks, Carol. I didn't mean to give the impression that we're taking that approach. We do have an implementation plan which is in development, so we would absolutely need to have those proper approaches and checks and balances in place. Absolutely.
Okay.
Thank you. Well, thanks everyone. Thanks for coming this morning and for sharing your thoughts. It's all been incredibly useful, and we can feed it into our ongoing work, and look forward to speaking with you again as we get into that next level of detail in our next session. So I hope you have a good day, and thanks very much.
Thank you. Bye.
Thanks. Thank you.